It's a pleasure for me to be back in UAB, not in person. And it's even a bigger pleasure to see one of my teachers, Dr. John Waterbo. I was looking for Dr. Jeff Roseman. I quickly look at the participants list. I didn't see him. I'm sure he'll pop up at some point. So thank you for giving me the opportunity. So yes, I left UAB about 20 years ago, last December. So I've been here since then. So let me remind you of my connections to UAB, because I look at the names and I didn't recognize any of the names except Dr. Waterbo. So you probably don't know the history of UAB. So when the global university concept was an infant, some of the visionaries at UAB thought about it. They decided to take the classroom to the students in other countries where the knowledge was needed. So that was 1987-88, and I happened to be one of those lucky students. We were in Chiang Mai, Thailand, and the person who was instrumental in that effort was Dr. Uwan Navia. He was second dean, I think, of the UAB School of Public Health. And some of these people you probably may not recognize. I think this was Richard Rennie here. He was the dental school dean at the time. Joe Walker and some of the other luminaries here, and our beloved local counterparts, Pradeep Phantom Unit and U Taiwan Kanchana Kamal. So these are the people who came from 4 countries to study from the UAB professors. 2 professors came to Chiang Mai, lived with us, ate with us, taught us. One from 8 to 12, the other one from 1 to 5, finished 2 courses in 1 month that you normally finish in 3 months in UAB. So very, very well thought out, very valuable learning experience to me as a student. And I think when things go back to normal, maybe we should try that model again. We are doing that here in NYU. We have a global university. We have a campus in Shanghai, Abu Dhabi, about 17 global sites in addition to our main site here at NYU. But you guys started that way before we were even thinking about it. So kudos to all those visionaries from UAB. And if you're wondering where the speaker is, right here, still the same height. I did not grow up since 87. And this is my beloved mentor. He came to teach in one of the courses. Just chronic disease epidemiology. I fell in love with the subject, fell in love with the man. My hair is also like his, except for the color, right? Dr. Roseman, are you in the audience? No?
I don't see him yet. So.
Okay, all righty, yeah. I put that slide for him. Actually, the history is that I was the very first student, the PhD student came out of your School of Public Health Epi department. There were 2, Charles Rotimi with R, Dasanayake with D. So I win as a joke. No, Charles graduated before me and he did very well. He went to NIH and he's doing very well. I stay in touch with my friend Charles Rotimi. So this is where I am currently, and for the last 20 years, I've been teaching, doing research, and providing services to the community. So here's my topic now. Do you have gum disease? The lay terms, pink in the sink. When you brush in the morning and you spit to your white enamel or whatever the porcelain sink, you see pink stains, droplets. Yeah, meaning you have gum disease, right? So this is an extreme form of gum disease. I'm not saying you have this form. You have some form, if neglected, if not treated, it is going to end up like this. So here's the data. Half of American adults suffer from gum disease. 47.2% have what we call periodontitis, inflammation of the tooth supporting structures for the periodontium. You break it down to mild, moderate, severe, you can see the proportions here, 9%, 30%, 9%. If you look at the numbers, people over 30, 64.7 million. So when I teach my first year dental students, their eyes pop up because that's how many people you have to treat. So job security is right there for them. So like I said, if you leave it untreated, unchecked, what can happen to you? not only you will lose your teeth, you will have malodor in your mouth and whatever, all these other local problems. There's a possibility that this can travel to the other parts of the body, distal sites, starting from the top to bottom. There's evidence that Alzheimer's disease, mild cognitive impairment, is associated with infection and inflammation associated with what is happening here. It is also known that there's a direct link between poor oral health in elderly, especially hospital-acquired pneumonia. If you treat periodontal disease in an elderly in an intensive care unit with chlorhexidine, you can reduce mortality from pneumonia by 64%. Hardcore evidence, right? It's not difficult for you to imagine the direct link. You swallow everything in your mouth, bacteria, the byproducts, and everything else, uh, and you're vulnerable, you're immunocompromised, you're old, you're on polymedicine, polypharmacy, is disaster. Type 2 diabetes, clear link. As you know, some of the physicians in the room can tell you there are complications of diabetes. There were 5 at the beginning. Now, the 6th complication is coming from periodontal disease. If you treat periodontal disease in a diabetic patient, you can control the sugar. If you control sugar, you can control the periodontal disease. That's a beautiful bi-directional relationship. So the insurance companies now pay for periodontal care if you're a diabetic patient. That's a policy victory for us, the researchers who have looked at this association. So my area has been, because when I was a graduate student, I decided I want to do follow-up studies. It's beautiful, but I don't want to follow them up for more than 9 months to 1 year. So I stick with pregnancy. I'll tell you the backstory to that. So the poor pregnancy outcomes, uh, perinatal mortality, low birth weight, there are tons of reports indicating the link between these two, and I'm going to expand on that using some of my own work and the current knowledge, global knowledge on this particular topic. Dr. Shrestha, when I'm reaching like 5 to 10 minutes before, give me a signal, and then I'll give people a chance to uh, ask questions. So my interest in this area actually came in Chiang Mai when I was sitting in a classroom, like probably the room that you're sitting in. These are my MPH classmates. There's a little room in the Chiang Mai Dental School. My professor was Chris Hale from UAB. I was taking a course in maternal and child health, and we had to do a project to graduate from that course. I was sitting in the back of the room, not the back actually, in the middle of the room. Is my good friend One Pen, Thai, Japanese, Chinese, Sri Lankan, whatever, all the people in the class. And I was thinking of, okay, what am I going to look at? And I have 7 brothers and sisters. And my mother used to say, every time I delivered one of your kids, I lost a tooth. Old wives' tale that you hear in many parts of the world, right? I was sitting there, I said, you know what? I'm going to take that as my theme, looking at oral health and pregnancy. So that was in 1987. And here I'm talking to you about that in 2022. So let's look at this preterm birth. That was the focus at the time. We didn't know much. There was nothing in the literature. We were blindly going after various pregnancy outcomes, trying to link it to poor oral health, right? So one of the things that made biological sense was preterm birth because of the inflammatory mediators associated with periodontal disease. Some of those mediators are also associated with preterm birth, right? So if you look at the preterm birth report card for US, C minus, 10.2%. Do you know what grade you got in Alabama? Anybody? I have 40 people listening to me. Feel free to unmute and speak. And if you know me, say hi, please. So Alabama got 12.5, a little bit better than the national average. So something you guys are doing well there. So now I'm taking it back to the first year MPH level. How do we measure the association between periodontal disease related factors and poor pregnancy outcomes? Let's narrow it down to preterm birth for simplicity. There are other things. You can look at low birth weight, preterm low birth weight, uh, perinatal mortality, you name it. I can do any one of those things. Just pick one. So you have outcome variable and independent variable. Let's simplify the periodontal disease to simple clinical periodontal disease, that there's a destruction of the structures supporting the tooth. But I can go further. I can look at bacteria. I can look at inflammatory mediators, the whole 9 yards. So here's my simple way of looking at it. Clinical periodontal disease. And I want to link that to too small, too soon babies, right? Preterm deliveries, right? Could be too small as well, preterm low birth weight then. So how do I link these two? You can think of various study designs, right? Prospective follow-up, retrospective follow-up, case control, experimental. You can look at any one of those things. This is the knowledge at the time I published this little figure. There were 34 studies saying that clinical periodontal disease is related to preterm birth. And then there were some studies that said, no, 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 it's not true. The people who look at plaque and salivary bacteria related to periodontal disease, same story. You go further, you look at this little crevicular fluid here, there's a serum exudate. You look at the cytokines against some of these periodontal bacteria, some associations, no associations. You go further, look at the systemic serum antibodies and cytokines against the periodontal pathogens. They're non-specific, by the way. There are some studies showing link, some studies failing. Let's take one step further. Let's look at the placental unit. Cord blood antibodies to periodontal bacteria, same story. Let's look at the amniotic fluid, immediate environment of the baby. There was one association at the time. I haven't updated this slide. I should at some point. And what is the gold standard? These are all observational studies, right? They are one level below in the hierarchy evidence, the pyramid. So gold standard is, of course, okay, then there's amniotic fluid bacteria also that I forgot to mention. So this was 2008 publication, and the gold standard is, as you know, is the randomized control trial. You get two groups of people, pregnant women with periodontal disease during early pregnancy, treat one group, wait until after delivery to treat the other group. Yes, there's an ethical dilemma. People have overcome that battle and have done these studies, and then see whether the outcomes are different between the two groups in favor of the treatment, right? That's the gold standard. So I'm going to summarize some of these studies for you. And so I'm going to start with the study that I did with UAB money. I think I got $300 in 1987, if I'm not mistaken, for this study. So I went to two hospitals with a Thai translator in the back of a motorcycle every single day, and I collected data. At this time, I was not even looking at preterm. I was looking at low birth weight, because you know what? There was nothing in the literature indicating the link between oral health and poor pregnancy outcomes. Just to show you, these are some of my colleagues. They're good friends. They're leaders in their fields now. Some are big shots in the ministry, some are deans. One person is the director of Thai Health. This person is a non-profit organization in charge of health of Thai people, not only oral health. So here's the study. This was what we call the match case control design. This is my first exposure to match case control design from our UAB professors. Sample size 110, 55 pairs. Look at some of these variables. Height, because taller mothers have larger uterus was the concept at the time. Prenatal care, no versus yes. If you don't have prenatal care, you're 4 times more likely to have a smaller baby, significant. And if you had clinical periodontal disease, you were 3 times more likely, again, confidence interval 1.4 to 8.3, right? And the DMFT is the number of decayed missing fill teeth, did not make the cut. So are there periodontal pathogens in the vicinity of the feto-placental unit? Let's jump from clinical periodontal disease, proof of concept. So how are you going to get preterm delivery? One of the things is that these pathogens and inflammatory mediators should be present around the fetus, right? I'm going to show you a study done by a colleague of mine. This is what we call N=1 study. I'm going to read it to you. A woman with pregnancy-associated gingivitis, that's the gum inflammation, experienced an upper respiratory tract infection at full term, 37, followed by stillbirth, dead baby, few days later. F. nucleatum, it's a very, very stinky oral bacteria. I smell that, I don't want to work with it. Was isolated from the placenta and the fetus. This is not known vaginal, cervical, placental pathogen. It traveled from the distant oral cavity to the fetal-placental unit. Examination of different microbial flora from the mother identified the same clone in a subgingival plaque that's underneath the gum, the white sticky mass that you remove with your toothbrush, but not in the supragingival vaginal plaque or the vaginal flora or the rectum. So my good friend Yupin Han concluded that if nucleatum may have translocated from the mother's mouth to the uterus when the immune system was weakened during that respiratory tract infection. This case sheds light on patient management for those with pregnancy-associated gingivitis. Like I said, N=1, proof of concept. Okay, this can happen. So this is useless, but I wrote it for publication just to summarize in global evidence. This was, I think, 2010. At the time, these are all the studies around the globe. When we published that, and there were so many other people thought this is important and they want to look at it. And I'll give you the bottom line here. I don't know whether you can read here. There were 50 studies saying that, yep, they're linked, 24 saying no, 4 said one component positive, one component no association, right? You can draw meaningful influences, but I just want to show you the activity of research around that arena at the time. Then all of a sudden, we threw the baby out with the bathwater. That's my story today. So reasons for that inconsistency. That's why I showed you that slide. Why do people find different things in different parts of the world when they're trying to look at the same thing? If I was given this in person, I will ask the first year MPA students, what do you think? I can do that today. So maybe John, you can ask them, right? Yeah. Methodological differences. Do I measure the periodontal disease the same way in Fiji, in, I don't know, Grenada, in wherever? Did they control for the residual confounding, smoking, alcohol, drugs? Very, very important factors in the Western model, right? And are there true population differences? And some people are not getting this, some people are getting that, right? So these are important epidemiological questions that you have to ask before you come to conclusions. So I'm going to address some of these one by one very quickly. Let's go to this residual confounding due to smoke, right? I did this study in Sri Lanka, where I am from. This was published in the Journal of Dental Research 2005. I wanted a group of women. I learned from my Chiang Mai experience. Case control is not the best model, right? We don't know whether it's the chicken or the egg. I needed to study a population of non-smoking, non-drinking, and non-drug using women who are in pregnancy age. Where do you find them? It's a bit difficult, right? So I went to Sri Lanka because I know they don't. Number one, economic reasons. Number two, the culture, right? Number two, education, female literacy is very high, and the free healthcare. So they start getting the prenatal care very early. They're educated. They don't have money to buy alcohol, cigarettes. They don't have money to buy a loaf of bread, right? So these are the kind of women. So I said, okay, I'm going to go there. And I'm going to study this prospectively, not retrospectively, okay? So we found such a population, and this is where I come from. I'm from this little area, Kandy with a K, not C. Ironically, the dental school is also in Kandy. That's with the C Kandy, right? But this is Kandy. Anyways, this is where the tea plantations are in Sri Lanka. So if you are a tea drinker, John, you're drinking a cup of tea? No? Yeah. So these were the, okay. All right, yeah. So tea is coming from that area. So I've been there. And I had this poor tea pluckers. This is the coastal region. This is the central part of the island. So what I did was I got a fairly large sample size, calculated the power. I knew how to calculate the power and all that. Second trimester, first trimester, they don't want you to touch them, you know, potential lawsuits and all these other problems, right? Second trimester, fairly safe. They can sit in a dental chair. You can do an examination without them throwing up on you. So measure the clinical periodontal disease, standardized examinations, and you get the birth weight and the gestation age. Two outcomes now. We can combine them and get a composite outcome. And then they're rural and homogeneous now. They're first time pregnant. So all the other pregnancy related things are taken out of the equation by design. That's the beauty. No tobacco, no smoking, no chewing, no alcohol, no drugs. I told you why that is the case, right? This is as clean and pure that I wanted it to be. So this is what we found out. This is my people with periodontal disease 66, people without periodontal disease 160. So I'm looking at age, they're very similar. The height, again, I'm still looking at the height. Ethnicity is similar to the island population. Primary education, 92% of the people with gum disease only had primary education compared to 68%. These people came to prenatal care, the first prenatal care, 2 weeks later, people with gum disease came 2 weeks later. This all fits to a model, right? The hypothesis, they are less educated, less access to care and that sort of thing. So now I have make a mental note. I have to control for these things in my final analysis, right? So there are differences here. So this is that model. 226. This is the preterm delivery, 7.5%. Here's my healthy pregnant women, 5.6. My periodontal disease group, 12%. You just eyeball, there's a twice as higher risk of preterm delivery. I mean, yes, preterm delivery in my exposed cohort. So the crude association was 2.3. When I adjusted that for the education and the prenatal care, remember I adjusted for smoking, alcohol, everything else, number of pregnancies in my design. So this association disappeared. 2.3 became 1.9, 0.7 to 5.4, right? That's another way to look at this association. So where are we now? The case control study said, yep, there is a link. A little cleaner, a little bigger. Prospective follow-up study said, no, probably not. Let's go forward now. Let's pool the results of all the observational studies, okay? I don't know whether your students are familiar with meta-analysis. I'm assuming. Yeah. Okay, very good. So here's a forest plot, right? So these are the studies, individual lines are the studies. Here's the point estimate and the confidence interval, right? And here, the summary. What is this value? 2.83. Confidence interval, significant, right? It's similar to my Chiang Mai study. So these are all the observational studies. Outcome is preterm low birth weight. Maternal periodontal disease is the exposure of interest, right? So keep that in mind. So pool all these studies, including our study in Sri Lanka right here, 1.9 study, is including all that, average 2.83. That's about, 3 times more likely to have a poor outcome if you're exposed. 2 to 4-fold increase in preterm low birth weight in those with periodontal disease. Let's go back to our model, right? Now I want to do this intervention, the gold standard. At the time, there were 6 studies saying that yes, we can reduce. 4 studies said no, we can reduce preterm delivery. I'm going to give you 2 or 3 studies, just the taste of it, right? And then you can discuss together. This is coming from South America. Nestor Lopez, a friend of mine from Chile. What he did was, I set up these 3 slides the same way, okay, so you can follow it. These are the 2 groups. Treatment is this, whatever the color it is, a little colorblind, like pinkish, whatever you want to call it. Yeah, yeah, magenta, whatever. The other one is this yellowish brown color, right? The sample size is in parentheses, 188, 163. Here's the outcome, preterm low birth weight as a percentage. He reduced in the control group from 10.1 to 1.8%. statistically significant, not due to chance, right? His treatment was what I call tender loving care. They bring them as needed, take care of their periodontal health, right? Not a standard protocol. If they needed cleaning, they gave the cleaning to these women. So this kind of, can do it in a, well, you can do it in individual clinical settings, but as a community intervention, it could be a little harder to quantify the effect of which component of the intervention brought the reduction in your outcome. Now I'm going from South America to North America. Mikulowicz from Minnesota did the same thing, larger study, 405 to 407. Here's the preterm delivery, no difference, 12.8, 12%, not significant. But Mikulowicz broke his data down and he was looking at spontaneous abortion and stillbirth. Perinatal mortality went from 3.5% to 1.2%. Statistically significant. They downplayed that in their NEJM article in 2006. And then we went and we got the data and we reanalyzed and we published. I talk about that a little later. So here's the third study from South America, similar but a larger study. This is my late colleague from UNC, Steve Offenbacher. His study is even larger, 2,000 women now, right? 903, 903. This is the cut of 37 weeks, traditional preterm delivery. 11.5 in the control, 13.1 in the treatment group, no difference, significant difference. He lowered the cutoff to 35 weeks, 4.6, 4.7, no. Now these are large $1 million randomized control trials funded by the National Institute of Health Dental Research. So they decided no more studies on oral health and pregnancy outcomes. This is what I call the baby out with the bath water, without taking a pause and looking at all the other potential explanations. I'm going to pull the results of the experimental studies for your benefit. Here's my second forest plot. We're going to break it down to low quality studies. Even among randomized control studies, you can have low quality, right? You know the quality of studies you measure when you do a meta-analysis, the biases, right? And the high quality. Low quality, yeah, there's a reduction, right? What is the reduction? Why am I not seeing that? I'll put it here. What's the reduction? There's about 48% reduction when you pull these, kind of low quality studies. But when you get the high quality studies, larger studies, including Offenbacher, Mikulowicz, and some other studies, this reduction from 48% went down to about 7% and it's not statistically significant. Okay. Again, now these are the meta-analysis of randomized controlled trials. Preterm birth, 37 weeks is the outcome. Let me see. These other Zoom windows are bothering me. Okay. 48% reduction, 37-week gestation. Treatment group in low quality studies. High quality studies showed no significant reduction. But that is not the end of the story. Okay, that's my point. I'm not trying to get additional funding, but I'm telling you the story.
Yes, you are.
Thank you, sir. Thank you, John. So I'm going to bring you to 2000. When is this published? 2019, 2020. Effect of periodontal treatment in pregnancy on perinatal outcomes. Let's switch the outcome. Okay. A systematic review and meta-analysis. I think I highlight somewhere. Let me get this people out of my way. How do I do that? Okay. I'll keep one picture here. Sorry. So let's look at these studies. Okay. Journal of Maternal Fetal Neonatal Medicine, 2019 publication. Okay. Remember, outcome is not preterm delivery. This is perinatal mortality. Okay. Now here I'm looking at between periodontal treatment during pregnancy and perinatal mortality. Look at all these studies. You know how this is set up, right? Experimental control, events out of total, the weight, odds ratio, summary odds ratio. Look at the reduction, 47% pooled estimate. 70% to 7%, right? It encompasses what we saw in the periodontal disease and preterm arena. So you can of course go and get this article and then study further. So here now I'm going to uh, preterm birth that earlier we discarded. That is coming very close, 0.6 to 0.98, right? Now outcome is pregnancy and preterm birth, right? So we have sort of hastily. I'm going to tell you why it happened and what I think at least happened. Let me move on because time is running out for me. 33 minutes. Okay. So now I'm going to go and look at the mean difference of birth weight. Again, there's a reduction. The increase in favor of treatment, right? Mean difference about 250 201 grams mean difference in favor of the treatment. Let's look at the economic impact of periodontal care now, because I have done a study on this topic. I'll give you the introduction to that. This is a former UAB College of Dentistry person, Margie Jeffcoat. He was the chair of periodontal disease, periodontology, later the dean of University of Pennsylvania. And she was looking at the impact of periodontal therapy on general health. Evidence from insurance data for 5 systemic conditions, including periodontal disease, which is a chronic condition. So I'm going to break it down for you very quickly rather than wasting your time. So here is the total medical costs, about 8,000 people, first pregnancy. This is the time period. Total medical cost per subject per pregnancy was about $3,000. But if these women were treated for periodontal disease, she claims that it went from 3,200 to 2,400. Okay, a significant reduction if these mothers were treated for periodontal disease. Let's go further and look at the real numbers. You can download these articles and study on your own. So here I'm going to set it up the way you're used to. Here's my untreated 8,000 women. Here's my cost per subject for pregnancy. Here's we are controlling for age, of course, gender, and the type 2 diabetes mellitus, because cost is related to some of those things. Gender is the gender of the baby, not the mother. I don't know, mother is still mother, right? Female. Treated, sample size 22. Cost 866 subject per subject per pregnancy is what her paper reports. First pregnancy, 74% reduction in cost if you treat. Second pregnancy, 47% reduction. So she made that claim. So I'm going to conclude this with some data from more recent work that we have done here. This was one of the ones that I just had from NIDCR. I want to look at the differences in maternal and neonatal hospital charges in relation to periodontal disease and pregnancy outcomes. Okay, so here's my study. I had to screen about 2,000 people. There's a beautiful hospital right across the street from where I work. It's called Bellevue Hospital. It's a mental institute in the old days. Now they provide, care to poor and underserved and all the other people. It's a public facility. My son works there, by the way. So anyway, so I went there, I screened all these people, and I had my eligibility criteria, like they have to be certain gestational age, single gestation. I need to get the informed consent, no antibiotics for dental exam, and some of the reasons why they didn't want to participate. Spouse, husband or boyfriend didn't want them to participate in a dental study. I thought that's fascinating. Some of them are single mothers, but that person had a say. Fear of infection, they were planning to move, they had medical problems, usual, right? I planned my study for 80% power. So I had about 265 consented. So I had enough subjects. I got outcome data from 246. That happens when you work in a big, large public facility. I had twins, I had elective abortion, These people lost to follow up. I couldn't follow them. They went to a different location to delivered at home. I don't know. After I recruited them, they said, no, I need antibiotics or whatever it is, Here's my primary outcome, 10%, 2%, which is similar to the national average, New York average. Full term, 89, 90%. And I had about few spontaneous abortions. I can do meaningful analysis to see whether that was related, right? It's only anecdotal. So what I did was I did the clinical exam. We call it PSR. It's a quick and dirty way to get an idea of what is happening. But I took serum to look at the IgG levels against periodontal bacteria, C-reactive protein. I look at all the cytokines against this bacteria. I look at cervical, vaginal bacteria, and oral bacteria. It's very, very sophisticated, very complex, study with a lot of people involved in that. And we collected our samples early pregnancy, 15 to 23 weeks. Okay. So I'm not going to talk about the outcome data here because it's all published and all that. I'm going to focus on this cost part because I'm trying to finish this right now. So, and the outcome here, maternal infant hospital stay and cost in this slide, not in the whole study. The whole study was designed to look at the outcomes. So here, I'm going to share with you, if I get out of the full screen mode, I'll be able to do this without these additional things bothering me. Okay. So I will orient you to this one. Here's my 235, right? So just to get an idea, they're a little bit older than my Sri Lankan women. Ethnicity, New York City, predominantly Hispanic. White, Black, Asian, mostly Hispanics are white mostly. And I had a fairly reasonable distribution here. Single, half of them. Only high school, 2/3. Annual income, you can say most of them less than $25,000. That's why they come to that particular facility for care. So of course, in a proper study, you have to look at the smoking, alcohol use, drug use. Yes, sidebar talk. When I submitted this proposal, I had infant hair samples to be analyzed for intrauterine exposure to drugs. And the reviewers said, no way. They were going to shut me down. So they said, if you do that, you have to report these mothers and you're not going to have a study. So I bent backwards. I said, all right, I'll take it out. So I compromised science to get the money, John. I'm sorry. Okay. So,
do what you got to do.
You got what you got to do. Yes, yeah. Exactly. So I still kind of, I don't know, I could not argue with them, saying that, they were right. I had to report if I have an infant hair sample positive. And then anyway, so of course you look at the dental habits. Now here's the bigger picture, right, of the women, preterm, 37 weeks. In this public hospital, maternal charges, by the time they go home, they owe about $10,000. But the baby of preterm is about $45,000. Okay, I don't know who's paying these bills. The total on average about $50,000, right? So the full-term group, there are some significant differences. The infant charges significantly less, 44,000 to 3,000, and total charges 50,000 to about 10,000. And the infant stay and the maternal stay, as you can imagine, about 3 days, 2 to 3 days. But the babies, preterm babies, stay in the hospital a lot longer than full-term healthy babies. Now here, I'm going to break it down into 4 groups, right? So look at the groups. If PPO is poor pregnancy outcome, no. Periodontal disease, no. That is my reference group. Okay, keep that in mind. And I'm going to compare these two other groups, such as no poor pregnancy outcomes, periodontal disease, yes, just the exposure, but no outcomes. There's a slight difference in cost, but not significant. These are the p-values at the bottom. But look at this group. Group 3 is the outcome is there, exposure is not there. Group 4 is outcome and the exposure is, that's the double group, right? Outcome is there. So compare that to the reference group 1 to 4, right? Here's the group 4. Outcome, poor pregnancy outcome there, periodontal is there. And if I compare that to my reference group, statistically significant reduction in the cost, right? So what am I? This I threw for Dr. Rosman. He's not here, so I'm going not to talk.
Yeah,
about
he's
it.
on the line now. He joined. Yes.
Hi, Dr. Rosman. How are you?
I'm doing fine. Sorry I had a little trouble getting in, but I'm on now.
This slide is for you. I
Oh,
just
that's sweet.
specifically put it for you. This shows you high IgG levels against one group of oral bacteria, Actinomycetes comitans. So here I'm comparing maternal charges in the high IgG group compared to maternal charges in the low IgG group, right? Notice there are some significant differences. I am still scratching my head. Maybe you and I can write this paper. I will send it to you. And infant charges, same. Total charges, same. Maternal stays same. Infant stays same. I don't know how to explain this. I can find enough in the literature. So if you don't mind, I know you have a little time in your hand, so I'll send it to you. So let's look at it together. Those of you who don't know Dr. Rosman, he was trained as an immunologist before he became an epidemiologist. So thank you, sir. Thank you for joining. So I'll move on. So in my multifactorial analysis, of course, right? What does it really mean? Now I'm looking at the total hospital charges, preterm delivery, significant, preterm delivery 35 weeks, not significant. Only the 32 weeks significant. Total neonatal complications, significant, periodontal disease, significant. So what do I conclude from that one? As expected, both mothers and infants had higher hospital cost in the periodontal disease plus preterm delivery plus group. And after controlling for other factors, periodontal disease was still a significant predictor of higher hospital charges. Association of hospital charges with immunoglobulin levels needs further exploration. So here's my conclusion. Just forget the national figures. Just based on what I saw, $48,000, $50,000. So in this city, or this state rather, 385,000 babies born too early, right? That's about $18 billion public health problem. So probably we are just looking at the tip of the iceberg is my thought currently. Treating periodontal disease during pregnancy may still be beneficial to sort of reduce some of these costs, because treating periodontal disease is not rocket science, and it's not life-threatening, it's not invasive. So we can really do that, find a safe period. We have enough data to show that it is safe to treat periodontal disease during pregnancy. And of course, I think we still need better and larger studies to shed additional light. So let's go back and revisit the old animal studies, okay? Let's go back now, 1970s and all that. Proof of concept or principle. People who injected pregnant hamsters with the periodontal pathogen Porphyromonas gingivalis, what did they see? They had smaller fetuses, 20% reduction in weight, okay? And increased levels of TNF alpha and prostaglandin E2, which is related to opening of the cervix when the mother is ready to deliver at the site of infection and in the amniotic fluid. It goes back to 1994 Collins. So go back and read some of these studies if you're interested in this area. I would like the doctoral students to pick this up and then carry forward and update our knowledge on this particular topic. I'll be happy to support as an external whatever advice or whatever it is. So humans are not animals, but here's my summary, okay? So what is happening in your oral cavity? All this is, stained plaque. There are 600 different species of bacteria in your mouth. I bet some of you didn't know that. There are 600 friends and enemies in your mouth at the moment. So they can actually threaten the developing fetus of a woman, not by eating the baby, bacteria eating the baby, but the infection, inflammation, right? So as you saw, it's a controversial topic. Observational mechanistic studies have shown positive and negative results. Randomized trials, some failed. Meta-analysis studies showing some promise that if you change the outcome, maybe you will see the bigger picture. And the economic analysis indicate that periodontal treatment may reduce pregnancy cost. not costs, okay, COTS, okay. Come on, Anand. All right. So what is the truth? Are they really linked? I have 44 people. If I ask them, if I do a poll, how many of you think it is linked? I'm not going to do a poll, but some people probably won't believe it. Some people probably think it's possible. Some people think it is this. A bunch of blind men trying to describe the shape of the elephant. And I am being one of the blind people. Try not to be blind because I was trained well at UAB not to be blind, but this is one way to look at it. So here's my alternative explanations for lack of an effect of treatment. Okay. Let me get that. Okay. If the women have enough periodontal disease, they're like 25, 26 years old. That's not the age for you to have enough disease. Periodontal disease is a disease of age, old people, the grandmothers, grandparents, elderly uncles, aunts. For the periodontal disease treatment adequate, you bring a pregnant woman, you scrape their teeth for 10, 15 minutes, you send them home, hoping that that is going to reduce a major pregnancy outcome. To me, that is kind of naive. Maybe that is why Nestor Lopez's Chilean study worked and the large NIH studies didn't work. I'm just putting these questions to you. Would the periconceptual periodontal disease treatment and maintenance of good oral health throughout the pregnancy have made a difference in outcomes? This study is not done. I wanted to do it. You can imagine the challenges one would face. If somebody can figure this out, I'll be happy to be a part of that. SRPs, that's scaling and root planing. When we poke around the teeth of a pregnant woman, we're going to release the cytokines and the bacteria to the bloodstream. And we cause transient bacteremia, right? And now the beneficial effect and the harmful effect of that same action maybe is what we see. So these are like points that I raised in a review paper we wrote on this topic. And how about the role of inflammatory mediators from subclinical and clinical infections from other parts of the body? As I told you, when I look at CRP and other inflammatory mediators, you can label them as coming from periodontium. They can come from any other part of the body. So these are sort of open questions in my mind in this arena. So hence I subtitled this, Did We Throw the Baby Out with the Bathwater? So let's look at the policy standards. This is from the Journal of Clinical Periodontology, Periodontitis, Adverse Outcomes, Consensus. Let's see what they say. Additional research is needed to better understand the pathophysiology, to develop the most appropriate treatment modalities, as well as to identify subpopulations of pregnant women that will benefit. It would be inappropriate to conclude that these seemingly contradictory findings from observational mechanistic versus interventional studies indicate a lack of rationale for further research. This is the OBGYN community, American College of OBGYNs. Their conclusion, despite the lack of evidence that prenatal oral health improves pregnancy outcomes, ample evidence shows that oral health care during pregnancy is safe and should be recommended. Improved oral health of the woman may decrease transmission of potentially cardiogenic bacteria to infants and reduce children's future risk. That's based on some of the work we did in Alabama with Paige Caulfield. For many women, OBGYNs are the most frequently accessed healthcare professional, more than they go to the dentist, which creates a unique opportunity to reduce or educate women throughout their lifespan, including during pregnancy, about the importance of dental care and good oral hygiene. So I believe that's my last slide, and I want to thank you, the UAB, Dr. Shrestha, Joanna Carson, the Dean, the Chair of the department, my teachers, Dr. Rosman, Dr. Waterbo, and other friends that might be there in the audience. So just a final note, I still stay in touch with my Chiang Mai friends. Jeff, this is like last year or the year before, just pre-pandemic. Some of these my classmates, we gather every few years to have a chat. And I took this picture from one of my classrooms. I teach sometimes in the evening. This is Empire State Building lit, as seen from my classroom here at NYU.